evening, everyone. This is my first question. Someone who's diagnosed as having Guillain-Barré syndrome is presenting with a rapid onset ascending weakness at 10 days after having a gastrointestinal infection. And there is a plan was made to initiate treatment with the plasma exchange. As you know, the standard treatment for Guillain-Barré syndrome is either usually a plasma exchange or or IVIG, IV immunoglobulins. And as you know, plasma exchange, it's quite effective for this condition along with number of other conditions. But sometimes we may run into certain issues. So the question is, which of the following electrolyte imbalance are common with this with plasma exchange? And these are the options: hypocalcemia, hypophosphatemia, hypermagnesemia, hyperuricemia, and hyperkalemia.
Hypocalcemia.
Okay, very good. Why does that happen?
So because plasma constitutes a majority of the fluid portion of the blood, and that contains calcium. So when there is an enormous exchange of the fluid, so it tends to cause hypocalcemia.
Yeah, okay, that is one mechanism. What is the other reason? What is used for anticoagulation? Does anybody know? When you do plasma exchange, we use a certain anticoagulant normally. Generally, we try not to use heparin purely because when you do plasma exchange, just you mentioned, you also remove some of the clotting factors as well too. Because sometimes you don't exchange everything with FFP, you partly exchange it with albumin and then partly exchange with FF, fresh frozen plasma. Yeah. So what is the anticoagulation which we typically use for this condition? No? Okay, not a problem. See, basically, what we do is that we use citrate as an anticoagulant for this treatment. Okay, so what happens is the citrate, the calcium is chelated by sodium citrate. So that is also one of the other reasons for developing hypocalcemia. So generally, what we do is that when somebody is undergoing plasma exchange, whatever the etiology might be, we often have to give them a calcium supplementation, usually in the form of IV calcium before and during the procedure, so that you can reduce the risk of hypocalcemia. There are other complications like cardiac hypolemia, anaphylactic reactions, etc. But the most common electrolyte disorder or abnormality that you will come across at the time of plasma exchange usually is hypocalcemia. And this is one of the main reasons why these people develop hypocalcemia. So generally, it's very well tolerated. Anaphylactic reactions and all are relatively common because we're infusing FFP from other patients, etc. So you often give them, prophylactic antihistamines as well as steroids at the time of initiation of treatment. There are various indications when you might give plasma exchange, and these are the conditions which is commonly used actually. When it comes to nephrology, the three main indications that one would use plasma exchange will be Goodpasture syndrome. You're familiar with that? We had a case on that last time when I did a class about 10 days back. ANCA positive vasculitis, typically we don't use it for everybody with ANCA positive vasculitis, but we consider that particularly if somebody's got a pulmonary hemorrhage, because one of the bad prognostic markers in both Goodpasture and ANCA positive vasculitis is the presence of pulmonary hemorrhage. So we want to bring the antibody down as much as you can, and one of the treatment that you would deploy would be plasma exchange to remove the antibodies. You also do other treatment like intravenous steroids, cyclophosphamide, etc. But if they have evidence of pulmonary hemorrhage, particularly you almost invariably use it in Goodpasture syndrome because most of them, they do have pulmonary hemorrhage. But in ANCA positive vasculitis, you only give it if the renal function is getting out of hand or they develop pulmonary hemorrhage requiring ventilatory support, etc. Otherwise, typically, we don't need to do that. The third indication with regards to nephrology one might use that would be hemolytic uremic syndrome. Again, we get a scenario, last week, and particularly in what we call as an atypical HUS, which is a non-diarrhea related hemolytic uremic syndrome. There are other indications that one might use it as well, but we often have a lot of better treatments. For example, multiple myeloma. I can't remember the last time we used plasma exchange now because we do have other effective therapies like bortezomib, etc. Okay. Sorry, any question on that one? Now, the next question is, it's a 32-year-old male who is being investigated for hemoptysis. Okay, he is a non-smoker and has no respiratory symptoms of note. His investigations have been done. He's got renal impairment with a serum creatinine of 201 micromoles per liter. He's got 2+ protein and plenty of RBCs. Okay, fine. All right. Sorry, I'm just refreshing myself with regards to the question. So what sort of things will go through your mind when you have a scenario like this?
ANCA-associated vasculitis.
Okay. See, basically the way you look at it is that he's got evidence of both renal and lung involvement. Yeah. Yes, isn't it?
Yes.
So he's got hemoptysis and he's got evidence of glomerulonephritis as evidenced by elevated serum creatinine, proteinuria, and hematuria. So what I call that is we call it as pulmonary renal syndrome. Okay. 1 second. For some reason, my Zoom is not letting me open the chat. I don't know whether it's something to do with Mac. I'm not too sure. So if you have any things, you can ask me directly. Actually, otherwise I'll have to stop the slideshow and look at the chat. That's what I have to do. Okay. So he has something called pulmonary renal syndrome. So what are the causes of pulmonary renal syndrome?
Good pastures.
Okay, very good. Somebody already mentioned ANCA-positive vasculitis. Yeah. Yeah, you already mentioned that somebody. Yeah. Okay. So ANCA-positive vasculitis, good pastures, and then
Granulomatous is polyangia GPA.
yeah, they're all very similar. Yeah, it's like ANCA-positive vasculitis. Yeah. Okay. Rarely you can have something like SLE as well. But that typically is very, very rare. But those two are the more common causes of good pastures and ANCA-positive vasculitis or granulomatous polyangiitis, whatever. Those two are the major causes of those things. So the way, we went through that the other day, but remember that if good pastures generally tend to be a very rapidly progressive, generally symptoms tend to come in over a matter of few days to 1 or 2 weeks, whereas vasculitis can linger around for a much more longer time. So typically the patient good pastures tend to be a lot more thicker than somebody with a vagueness or an ANCA-positive vasculitis. Okay. And again, ANCA-positive vasculitis, the other clue will be upper respiratory tract involvement. Remember, we discussed the other day. They may have features of sinusitis, etc. Yeah. So if they have that, it's most likely to be ANCA-positive vasculitis rather than good pastures. That's something will give you a hint. Okay. She done a linear renal biopsy, and what you see is the linear IgG deposits along the basement membrane. So now, what is the most likely diagnosis, or what antibodies are likely to? Sorry.
Good pasture syndrome.
Good pastures. Very good, sir. Just speak. I don't know whether it's my audio. I'm not too sure. Yeah. So it's likely to be good pastures. What will you expect in same question? What will you expect in ANCA-positive vasculitis?
In ANCA-positive vasculitis, there will be no deposits. It's a posse-immune deposit.
Exactly. Very good. Yeah. Very good. That's right. So that is what you will see. That is why it's called posse-immune glomerulonephritis. Because if you look at the light microscopy, what will they both will have? What will you find in the light microscopy?
In light microscopy, usually it's a rapidly progressive picture.
No. Rapidly progressive will be
sorry. Granulomatous.
No, not
Crescentric.
Crescentric glomerulonephritis. That's right. Yeah. So with the light microscopy, one cannot distinguish between good pastures or ANCA-positive vasculitis. The only way to distinguish that will be by looking at the immunofluorescence or by looking at the serum markers like ANCA, anti-GBM, etc. Okay. But in the immunofluorescence, what you find in good pastures is linear IgG deposit on the basement membrane, whereas in ANCA-positive vasculitis, it will be posse-immune. What I mean by that is basically you do not see any immune deposits. Okay. Likewise, let's say the similar patient, there is no evidence of hemoptysis. Instead, it's a 30-year-old woman or 25-year-old woman, whatever. You're suspecting it's going to be something like SLE. Then what you might see, we discussed it the other day. This is more like a rigorous refresher for the
full house
exactly.
stain.
Very good. Okay, this just again reinforcing it so that you guys remember it really. So if you see SLE, what you find that there will be IgG, IgA, C1q, C3, etc. So if you see that full house immunostaining, because SLE can also present with a crescentic glomerulonephritis, particularly if you have a diffuse proliferative glomerulonephritis. Okay, so though crescents are a bit rare, but you can still get it. So if you have a full house immunostaining, think of SLE. The linear IgG, think of good pastures. If it's past immune or no immune deposits, you think of ANCA positive vasculitis. Does that make sense? Yeah? Yeah, it's clear?
Yes, sir.
Yes, sir.
Yes, okay. Any
Yes, sir.
question?
Yes.
I'm really sorry. For some reason Zoom is not I don't know whether it is because of my laptop, I'm not Mac, I'm not sure, but I'm not able to open the chat box. If you do have any questions, can you please stop me and ask me? I don't mind that. Otherwise, I'll have to look at it only at the end, because when I'm sharing it, I know you guys are sending me chats, but I'm not able to. Just to 1 second. The only other option is to go to, then I have to stop the slideshow. I don't want to. Okay, so if you have answers, please tell me, okay, rather than typing it in the chat box. Yeah, because I'm for some reason, otherwise I have to stop the slideshow and then look at this one. I think it's maybe something to do with Mac and Zoom. I think unfortunately I'm not able to solve that right now. 1 second. Okay, so if you want to say something, just tell me. I'll stop and then I'll continue with that. Okay. Okay. So you know the answer. Here it is: anti-GBM antibodies. So likewise, if it is like a IgA nephropathy, you will see IgA in the mesangium, etc. Okay. So typically they are against type 4 collagen. There's a couple of things to remember with regards to anti-GBM disease is that there is a higher risk in smokers as well as in young men for pulmonary hemorrhage. So if we give a history of something like a vasculitis, young men smoker, think whether it could be anti-GBM disease. Okay. And the treatment is, the standard treatment is plasma exchange with IV steroids and the cyclophosphamide. Okay. Does that make sense? You have any questions on this?
No, sir.
Oh, fine. Just 1 second. Actually, the same thing. I just want to ask 2 things actually before I forget it. Okay. So let's say you got a situation. As always, it's important not just to answer the questions to know more about the condition that we are dealing with, we were treating. Let's say that you got somebody with an ANCA positive vasculitis or an anti-GBM disease presenting with an acute kidney injury. So what will be the initial treatment of choice? I briefly mentioned that here. I just want to clarify and discuss it. If you have any questions, because that's also equally important. Just a couple of pointers there. We got a guy. Okay, we diagnosed it. Let's say it's a 35-year-old guy. We diagnosed that you've got anti-GBM disease. We've done a biopsy, confirms that. Okay, he's got pulmonary hemorrhage. Yeah. So how would you treat him? That's my question. Yeah. How many treatment you do? What sort of treatment would you give? That is my question. Yeah, one at a time, please. Yeah.
Pulse dose steroids initially.
Okay, good. How many days would you give it for typically?
3 days.
Okay, very good. Then is that alone going to be sufficient?
We need to wait and observe.
Okay.
And then if it's severe, probably we'll go ahead with plasma exchange, or else if
Okay.
we go with cyclophosphamide.
Okay. No. What you have to remember is for anti-GBM disease, invariably you have to go for plasma exchange. Okay. It's not very clear cut in ANCA positive vasculitis, but when you have an anti-GBM disease or good pastures, you have to go for you have to go for plasma exchange. There's no other choice, because otherwise these patients will, even if they don't have a pulmonary hemorrhage at that time, they will go on, they are at a very high risk of developing pulmonary hemorrhage, etc. Because these antibodies are a lot more harmful than ANCA antibodies. Okay. So if you diagnosed it, you'll give them IV steroids followed by oral steroids, and then you choose cyclophosphamide. You can choose, let's say, IV or oral cyclophosphamide. Okay. Now, let's say, instead of this one, let's say we are dealing with a 25-year-old woman. Okay. And let's say she's got an ANCA positive vasculitis, but she's got a rapidly progressive renal impairment. She's got no evidence of pulmonary hemorrhage. What would be the treatment? What drug will you choose? What sort of things would you discuss before going for treatment with the cyclophosphamide? Or what is there anything else you can consider?
Here the reproductive phase of the lady has to be kept in
Azathioprine
mind.
can be considered.
No, please wait. One at a time, please. Yeah, go on, ma.
So because cyclophosphamide can cause problems with further conception,
Okay.
patient has to be made aware of the other options available, the other immunosuppressant therapies which are available.
Okay.
And maybe steroid plus other immunosuppressant group of drugs can be prescribed to her.
Okay, we will come back to that in a minute. I'll ask the guy who said about what you said about something about azathioprine.
Yeah, better to go ahead with azathioprine.
Okay, no, that's not, see, but here, see, when you come to this sort of things, whether it's a vasculitis or SLE, whatever, what you have is, you have two phases of treatment, okay? One is called the induction phase and then the maintenance phase, okay? Azathioprine is not something we consider for induction in vasculitis or even SLE, okay? So the induction phase is usually IV plus oral steroids. Then you have either cyclophosphamide, any other drug you can use. Anybody else is familiar with any other drug?
Rituximab.
Exactly, that's right.
Rituximab, yeah.
So if you have a lady who's of reproductive age, let's say she does not have a life-threatening disease like a pulmonary hemorrhage or something like that, the life-threatening disease, it gets very, very tricky. So you may not have a much option apart from going for cyclophosphamide. But if it's not a life-threatening disease, one option is you can discuss with them and go for rituximab. With rituximab can be safely given. It does not affect the fertility. Okay. Whereas cyclophosphamide, it certainly can cause infertility, particularly with the increased dose over time, like cumulative dose over time, etc. Actually, there is very little evidence that whether between IV and oral cyclophosphamide with regards to treatment in renal disease, at least as far as I know. Okay, that they are very similar, depends on individual preference. For example, I personally prefer IV, some guys prefer oral cyclophosphamide. Usually it's not there are no major differences. Okay. Now, we already discussed it. One is that what is that you can go for rituximab, particularly in young women. You worried about fertility, etc. What are the other side effects one would discuss before starting cyclophosphamide?
Hemorrhagic cystitis.
That's actually is very, very rare. We don't even use that. What is that drug olden days we used to give, Mesna. We don't give that. That's incredibly rare. It's something you should be aware of, but there are other things one need to be more aware of than that. Yeah. Anyone? Come on, there are a lot of things. There are few things which are very, very common. You already mentioned the most important thing, which is the fertility. The other thing is, see, any immunosuppression, what is it going to do?
Neutropenia,
Exactly. Yeah, that's it. So marrow suppression, increased risk of infection, hair loss is a major problem in some people. Some women are particularly very worried about the hair loss. Fertility, we already discussed it. Risk of billing and solve is very, very rare. I mean, these are the major side effects. That is the increased risk of hair loss, immunosuppression, increased risk of infection, increased risk of malignancy, and we already discussed about fertility is one of the most important things. Actually, it can also cause male infertility as well. A lot of times we often ignore that, but even in the men, you always have to bear in mind the risk of infertility as well when you give cyclophosphamide. So just to summarize really, so the induction phases usually go for steroids plus cyclophosphamide. You can consider rituximab in people who are worried about fertility or other risk of immunosuppression, etc. And then you go for maintenance phase. And usually with regards to vasculitis, the maintenance phases, usually steroids plus azathioprine. Though one can also use mycophenolate as well. With regards to SLE, it's actually MMF is generally preferred for maintenance phase compared to azathioprine. Okay, got that?
Yes, sir.
Yeah, understood. And any questions before I move to the next question?